Right, so I'm just going to tell you about a NIHR program grant that we've just completed in the UK, well, in England. And it was partly a challenging behavior project for both care homes and family care settings. And what I'm going to talk about today is the family care aspect of it. Okay. That's a list of the great and the good who helped us on this project, and you'll see the top names at the top are all a number of Interdem members, many of them who are, well, in this room or during part of this conference. And because it's independent research, I just need to point out that at the NIHR have asked us to disclaim anything that we have to say, which is good. The presentation in the program abstract names a number of collaborators, and these were people, because it's an applied research program, there were people in the NHS who led services. And so there were 7 NHSs involved, and most of the people who led the services, whose names are part of this abstract, are consultant clinical psychologists who do research and provide care in the NHS, and many of them lead teams. That's just the way the services were organized. And we obviously want to acknowledge Clive Ballard, who will be on next, who's been helping us really understand some of the data that we've got for this program. So just as a background, part of what we did was, it was an Interdem Cochrane collaboration with the Netherlands, where we actually looked at functional analysis-based interventions for challenging behavior in dementia. And that's partly because, as some of you know, the NICE guideline said that's how we should go about the treatments of challenging behavior. I note in the Cochrane library, they have placed this group of interventions not as treatments, but as rehabilitation. So it's a bit like cognitive rehabilitation. And I suspect that's partly because what we're trying to do is help people overcome some of the distressing disabilities that dementia can bring for some people and their families. So there were 9 studies in that review, as some of you would remember. And what the key things were, they were personalized and individualized. They had to be. They needed to be delivered by a skilled therapist. To really make any difference. That's what the evidence was. Motivated people, as Mira mentioned. Some of the work came from the States, from Linda Terry, where they had community consultants. And some of the studies were one of my studies, where we trained community mental health nurses to deliver the intervention. And what they're aiming to do is minimize its challenging behavior, minimize the impact of behavior changes, or what we call BPSDs, experienced by people with dementia and their caregivers. So there was a measurement issue there. And so what we came up with was to develop a training tool for practitioners, and Bob Woods, I would say, is sort of the brain behind this, sitting in the audience. And this was for both care homes as well as family care practitioners. And it has some modules. It's an internet-based tool where it initially trains the people to do what psychologists and practitioners might do, detect the range of problems that are the unmet needs and the range of problems that functional analysis interventions would need to be delivered by. And as you see there, there's personal biography. You've got to kind of get a handle on a bit of medical information, case notes, checking out from GP or anything else, what you know, and then asking people, any other information, asking families, asking whoever knows the person, what do they think, and the person themselves is triggering or contributing to some of these unmet needs and challenging behaviors. And on the basis of that, we developed an action plan method of leading the practitioners to select certain actions around health. This could be go and this person is diabetic and hasn't been reviewed. It might be worth asking the GP. Psychosocial care was the personalized care for the person. And of course, because this is in a family caregiving setting, what are the needs of the family caregiver, whether it's cognitive reframing or better understanding of the behaviors. That second bit for this family caregiver interventions is sort of book-based rather than e-tool-based, whereas the assessment part of it is e-tool-based now, and seems to be working okay still. What we did, the plan was to test it. We tested some of this with some 32 interventionists and specialist mental health teams across the UK, England, and they tended to be on the whole mainly mental health nurses in community teams, but there were some psychologists and some occupational therapists and one social worker. And the feedback was very interesting because when we first started, we did a nominal group process analysis. And when we first started, a lot of the teams were saying, oh, no, thank you, we've got enough to do with IT. But actually, when they started using the tool, it was exactly what we were doing in the NHS. We all have to use IT, sadly, to do everything these days. And people really engaged with it and were really quite motivated and confident and keen, because here was their answer for the bread and butter that they hoped they would earn in the NHS in the future. So we had our people trained, we had our tool, and so we went along to try and find out, it was a cluster analysis study, so we went to try and find our families. And we asked these teams and big services, 7 big services, are there people who live at home with dementia in your teams? And they went, yes, 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 we never know what to do with them. Please, can we have some help? So we set out to provide this and evaluate the use of this intervention. There were 33 specialist teams, and they were multidisciplinary, psychiatrists, OTs involved. And we examined every new case it was actually 6 and a bit months, to start recruiting families to this study. And we also conducted an in-depth study of the people we recruited and sought views from family caregivers and other stakeholders. And that's what it looks like, if you like. So we recruited people. We have some documentary evidence and analysis of the new cases, where they came from, what they did. We talked with practitioners. We then ended up with a cohort study, and surprise, surprise, that's because we couldn't find these people to deliver any treatment, so we couldn't do a trial, sadly, across England at this time. So we decided to do a cohort study and just follow these people up. And we've done some qualitative work to try and understand why is it that we can't actually get care, family care, for people who are struggling with behavioral upset. Where are these people? So we did some qualitative work. So our first headline, where are the families of this last group, a big group? Here we have, all we were looking for were people who were referred to teams who were living at home with potential of dementia, because they may or may not have had a diagnosis, and had an informal family caregiver. That's all they needed to do, nothing else, to actually start recruiting to our study. And as you can see there, only 8% of cases, apologies for the typo there, in those 6 months were eligible. 37% did not have a dementia diagnosis. And a lot of them were referred straight back to the GP or somewhere else. They were signposted before they even saw them. They looked at the referrer and said, not appropriate, and off they went somewhere. So this is before people even did anything. There was a large proportion in residential care, so we had to exclude them. And we only got 8% there, living at home. Interestingly, only sort of 5.7% didn't have an informal carer. So it wasn't just the absence of a family caregiver that scuppered us. And some small percentage died before we actually got to them to even check out whether they had a family caregiver or anything else. So they did, so there seemed to be very little of these hundreds of people we hoped we would get were actually even there in the referral system. It was very hard to even find out why people were coming into teams and going straight out again with nobody even seeing them by just looking at the GP referral. So our main outcome measure was the revised behavior memory checklist, which is, the reason we picked that is because that behavioral checklist is based very closely on the reports of family caregivers. So it's Linda Terry's scale that she's used for some of her studies. But we did also use the NPI and other things. We finally got 157 people. So that's all we recruited. And we threw in resources, I have to say, resources to treat, resources to find, resources for everything else. Quite an expensive study, but didn't find people. And what's interesting there is that you can see the maximum number of behavior problems that people can have on this scale is 24. You have a minimum of 5 because that was our cut point. If people didn't have 5, we couldn't label them as challenging or having enough of a case to begin treatment. And there you see, people, the range was 19, and 11 out of 24 is a whole huge number of behaviors. And you'll see later that if we've got time, the MPI scores. Our statisticians did some work. We found there was no real change in the groups as they went along. We reviewed them at 2 months and 6 months. Some got better, some got worse. So they did some cluster analysis, some clever stuff. And they couldn't find any predictors either. And there were a lot of measures, so they had to, although they were careful with making sure that they didn't kind of have so many measures, they were going to find something. They were statistically quite careful. There was no clusters, there was nothing. So we decided, let's go and have another little look. The timing of practitioner contacts. We collected every single time that somebody saw somebody in terms of the time, and that's easy to do because they all had to log in whether they'd seen people and for how long and where, all our practitioners in these teams. And what we found was that the practitioner contact times earlier, the first 2 months, so we followed up at 2 months and then again 4 months later, was more beneficial overall than later. So the earlier you actually saw somebody. So for those of us who, the family caregivers say, well, no, I'm all right, really. My GP's referred me. Just remember that might be you want to go and have a little look earlier anyway, okay? That's nearly done, okay. Practitioners were, the length of time was significant. Practitioners were intuitively responding, we think, to strain. So the correlation was the more contacts people had, the more behavior problems and poorer quality of life they had. And the length of time seemed to be a predictor for certain psychosocial variables in family caregivers. I'm going to just conclude with giving you a comparison. We looked at the cost and timings. That's just, you don't have to look at the scale, the measures, but what the costs were of the practitioners was exactly the same whether it was the first 2 months or later. So in the 4 months, the cost of the contact times was exactly the same across the whole period. So cost and timely early contact is as cheap, if you like, as seeing people later. I just want to conclude with giving you some very quick comparisons with our residential study. There's no time to give you some of the qualitative results that we've got, because we did do those. But what was surprising for us was that, well, not so surprising, that it wasn't very costly on overall health. So the health economic costs were not very costly on health service costs. Whereas if you compare it with our residential study there, the average NHS cost per resident, including their medication, was something like £1,986 in the same time period. This is a residential study. And equally so, interestingly, the antipsychotics were low, compared to other studies, but there you have a comparison of the drugs across the two studies. And we've looked at CDRs and NPI scores across the two groups. And interestingly, the NPI scores are exactly the same. So family care and residential care had the same number of neuropsychiatric symptoms. Yeah? What we've concluded is, and I'm going to leave the rest, but Jill Manthop helped us with this. The services had changed quite a lot in the NHS. We've got a thing in England called the payment by results, where we cluster people. And also, the second thing that happened was people were signposting people to memory clinics from these teams. They were being diagnosed and discharged across the country. So they were lost to the system. So Jill Manthop helped us think of some of our qualitative results. We did a lot of consultation and with a number of groups. So you've got people bobbing around in the water. It's random whether you get pulled out or not. If you keep swimming, a helicopter may come along, but maybe in a few years' time. You might get a raft and a belt for temporary shelter. And some people just choose to keep their heads down because they're just terribly frightened of going into care homes or being put on drugs. And a lot of that came out of some of our family caregiver and people with dementia consultations, as well as the practitioners who were dying to deliver services, but found it very hard to within the changing landscape of the NHS in England and the payment by results and the growth of memory clinics and the targets around those for seeing 600 and 800 new cases a year. Thank you.